Hello, Ms. Hogue. My name is Lori Peterson, and I'm going to do my assessment on the lungs and the thorax. To begin with, I have assembled all my supplies. I have my stethoscope, I have paper, ruler, my room is warm, and my patient has changed into her gown, and she has a blanket. I have her sitting up, her arms are in her lap, and she's in a rest state at this time, and no abnormalities noted at this time. So first I'm going to start with the assessment of the anterior thorax and lungs. So first I'm going to observe for any chest expansion, or I should say the shape of her chest, and note any barrel chest or pigeon chest, and also the position of the sternum with rise and fall with the natural breathing. I'm going to observe for regular rate and rhythm, which should be 10 to 12 respirations per minute. My client seems to be sitting relaxed and comfortable at this time, and no tripodic noted, which would be seen in a patient with COPD. I will be watching for any sternal retractions or discomfort with breathing, and any asymmetry of the chest wall during her respirations. My client appears to be relaxed and without any audible abnormalities noted at this time. Next, I'm going to palpate. I'm going to palpate for any tenderness and any surface masses. I will start with the client's right chest, and I will palpate for crepitus, any lesions, any surface abnormalities moving down the chest wall all the way the entire width of the chest. And I will palpate for tactile fremitus, which is a normal tone, and I'm going to have her say hello, 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 and hello. And this should be without any problems in her normal sensation or the normal sensation of hello. The next, I will place my thumbs together and have her take a deep breath in and out, in and out. And throughout my palpation, I will be assessing any abnormalities noted. And my patient has equal expansion of her chest wall, and I have felt no crepitus or any further abnormalities at this time. Next, I'm going to percuss her thoracic. So I'm going to start on the left. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3, 1, 2, 3, 1, 2, 3. And I will be percussing for pitch of tone and listening for any hyperresonance at this time. Hearing any dullness where there should be resonance could be an abnormality. It could be a pleural effusion or a tumor. And my patient appears to be comfortable, and I have not. The patient has appropriate resonance noted. Next, I will palpate for any tenderness. I'm sorry, I will auscultate, and I'm going to be listening for 3 breath sounds. One is bronchial, which is over the throat for bronchial, bronchial viscular, and viscular breath sounds. So I'm going to have my patient take a deep breath. In, 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 in. Now, bronchial viscular, in, out, in, out, in, out, in, out, in, out. And I will do this on both sides, down the left and the right laterally. And the final is viscular, and I'm going to have my patient take a deep breath in. And on the left, I haven't heard any abnormal wheezes or any low-pitched sonorous or any high-pitched sibilant wheezes. I will be listening for both fine and coarse crackles. Hearing any of these adventitious breath sounds is considered abnormal. Finally, I will assess bronchoscopy, and I'm going to have the patient say the number 99. Okay, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99. I will next have my patient say the letter E, which is egopny, which is soft but distinguishable. E, 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 E. It should be low, faint, and soft. And for the final one is whisper pectoralis, and I'm going to have the patient say the numbers 1, 2, and 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. And 1, 2, 3. And those sounds should be soft and audible. And at this time, I have not noted my client is free from any wheezes or any abnormal breath sounds at this time. Next, I will go into my posterior assessment. And with my posterior assessment, I will be inspecting and observing the scapula and looking for asymmetry. I also will inspect the spinous processes. They should be up and straight. Any curvature of the spine is due to scoliosis. And I will be observing the ribs should be in a downward slope at a 45-degree angle. And the client seems to be relaxed and comfortable at this time. And her breathing is regular rate and rhythm, and she's not having any difficulties noted at this time. Next, I'm going to palpate for any tenderness or any lesions at this time. So I'm going to use the palm of my hand and going to go over and palpate for any tenderness, any lesions, any muscle soreness, which would be due to a patient with COPD because they're having to struggle and use more of their accessory muscles. And also any local infection would be due to the temperature. The next thing is I'm going to palpate for any crepitus, which is kind of like Rice Krispies. And I don't feel any crepitus at all. Nice and smooth, no abnormalities noted. And I'm also going to palpate for tactile fremitus, which is normal with a spoken word. Hello, hello, and hello, 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 and hello. And the next thing is I'm going to do the chest expansion, which I'm going to put my thumbs at T7 and T10 and have her take a breath in and out, and they should not move more than 5 to 10 centimeters apart. And I have not noted any abnormalities at this time. And lastly is I'm going to auscultate the lungs in the same fashion as I did anteriorly. I'm going to have her take a breath in, and I'm going to listen for bronchial vesicle. Take a breath in. Again, again, and again. And now for vesicle, take a breath in, and again, again, and again. And on the right, in, and again, and again, and again, and again. And I have not noted any abnormalities at this time. No diminished sounds were noted during this auscultation. Next, I'm going to start with the client's right chest to the left, and I'm going to listen for any wheezes, crackles. So take a deep breath, in and out, 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 in and out. And I have allowed my patient time to relax and breathe during this exercise. And I have not noted any wheezes or crackles. And the last thing we are going to do is I'm going to further assess for bronchoscopy. And I'm going to have the patient say the number 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99. And this sound should be muffled and soft. Next one is egopny. I'm going to have the patient say the letter E. Say E, 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 E. The sound will be muffled but distinguishable. And the last one is the pector, whispered pectoralici. And I'll have the patient say the numbers 1, 2, and 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. And that sound should be faint and inaudible. And I have not noted any abnormalities on the anterior or posterior assessment. And this concludes my video assessment of the lungs and the thorax.